Thank you, AMOGS. Thank you, team Amravati, for inviting me. And I congratulate team Amravati for selecting a topic which is often neglected. And as we had the earlier speaker, so you have diagnosed a cancer with all imagings. You have done a robotic surgery. You are giving adjuvant therapy in form of chemo and radiation. What happens to the patient then? Who is looking after the post-operative, post-treatment needs of the patient? And the most neglected, most non-seen complaint, that is pain, is often misled, and most of the times it's not even treated. It's not that I'm giving this lecture because it's been told to me. I am also a certified pain and palliative care physician besides being an gynae-onco, because until I don't know how to treat pain in my patients, I cannot practice oncology. So that is how I also train myself in understanding what is pain and palliative care medicine. We do have a definition for pain, and this is the IASP definition of pain. I don't know how many of you were aware that pain also has a definition. So this is how we quantify and classify pain, and I guess everybody should know this. This was found in 1986 when the International Association of Pain met. This is what is happening. Almost 4.5 million people are suffering from cancer pain. Now please understand, this is WHO is doing the statistics. Imagine those unnoticed or unreported cases. You imagine the magnitude of pain associated with cancer treatment, all sort of treatment. And it is said that we often see even in our clinics, that 70 to 80% of them have moderate to severe pain, and it is known that 25% of them will die in pain. So I think pain is something that every oncologist should be looking at. It should be a part of armamentarium of a surgical, a medical, and a radiation oncologist, because this needs to be treated. What happens is the patient comes with pain and we often say, okay, you take this and you go. We don't know later what happens. As we all know, the pains are of two types: the nociceptive, that pain signals coming from nerve endings, and neuropathic pain. Again, nociceptive can be somatic, visceral, and neuropathic. So there are different methods, modalities to assess pain. There are different pathways of pain we need to understand. I'm not going to go into detail, but this is at least as practicing gynecologists you need to know. I have not got too much into the depth of this subject because the audience is gynecologists. Had it been anesthetists, again my presentation would have been different. So what is the problems that patients face in cancer pain? The biggest is QL, the quality of life. It is absolutely disrupted, and this we all need to be understanding also, empathetic also about this. And it is one of the most feared aspects of pain. What happens is, while a patient is undergoing a cancer treatment, the cancer word itself disturbs the sleep, the pain again disturbs the sleep, reduces the appetite, and the patient loses his concentration, and there's loss of work. There are too many holidays that the patient needs to take. So, and yes, coming to me also, I find almost every person who tells me, why should I undergo the treatment? It's better I undergo a suicide. So there are 60% suicidal tendencies associated with cancer pains. We have already discussed this. Why are cancers so painful is basically because of two reasons. One is very high level of prostaglandins secretion, which is done by coenzyme 2, and second is increased acidosis. So both of these combine to cause more pain in cases of cancer patients. This is something I would highlight to focus rather than going more on the treatment. I think what I understand practicing daily is we doctors are only the biggest barrier to pain treatment. How many times it has happened that the patient comes and then we really refer them, okay, you have pain, I have treated you. Patient is not resolved of that pain and we have referred that patient to someone. Pain and palliative care, I mean, there are a lot of postgraduate students. I think there are a lot of subspecialty coming in OBGY. This is one such thing that you can take up, pain and palliative care medicine. And we have departments. All cancer institutes across this country have a dedicated pain and palliative care department. And it is our job that patients who come with these cancer pains, irrespective whether it is a surgical pain, a medical oncology pain, or a radiation-associated pain, they need to be referred. You need to understand that there are departments. There is a specialty which who takes complete care as far as pain is concerned. So I guess we doctors fail to refer these patients to the correct department to see that a patient is alleviated of his pain. Otherwise, the entire thing goes on. The patient comes to you, you give painkillers, the patient goes to somebody else, gives painkillers, and they find that they are in a miserable situation, and then the suicidal tendencies increase. So doctors, patient family, and of course our healthcare system. I think our healthcare system has not projected pain and palliative care services the way it needs to be, and this will help not just in cancers, but pain and palliative care across all specialties is definitely going to help patients in a long term. So our healthcare system needs to be a part of this also. Secondly, what I understand is opioids. I'm not going to, as I said, the gynecologists are the target audience, so I'm not going to go into details of opioids, but there are so many hassles that I see every day, even with our anesthesia department also, when it comes in talking, when we talk in terms of giving opioids. I think there are a lot of hassles, and more than hassles, I feel these are self-created hassles due to half knowledge of opioids and the use of opioids and the government license and the government laws. So I guess generous use of opioids is what we really want as far as cancer pain management, which unfortunately at every level, at every step, at every specialty, at every system, we are lacking, and this is why the patients are suffering. And the biggest part is when you talk of opioids is the last point, the fear of addictions. Believe me, those in pain and palliative care physicians, they are much aware of what is addiction and what is not addiction. It doesn't mean that all morphine users are definitely in the future going to get addicted like that. It's not. When morphine is used by correct people, I'm sure they never get addicted to it. So these are the biggest barriers that we have. As far as gynaecology is concerned, what are the pain syndromes that we generally find? Most of the times, pain syndromes which are related to cancers, I think many must have observed that bone metastasis, bowel obstruction, and fistulas. These are the patients who genuinely come with real bad pain, and it is really difficult to even control with the highest doses of morphines, and believe me, it becomes very messy to treat these patients also. So these are the patients where pain management becomes a challenge, and that is where the pain and palliative care physician is required. Similarly, a lot of these patients suffer additional super infections. Again, those super infection causes a lot of pain, so that is something which is difficult to treat. Lymphedema may or may not cause so much of pain, but yes, it may be a cause of concern when there is excessive swelling of limb because of the lymphedema. The pain which are related to the treatment, well, as far as chemotherapy is concerned, intraperitoneal chemotherapy that we have been talking about, HIPEC and everything, I guess that definitely leaves a lot of pain. There are a lot of indwelling catheters around, and these patients also, so when you're doing this type of procedures, you need to have a pain and palliative care team who are taking care of these patients, because that pain needs to be most of the times tackled with morphines and nothing less than morphines. Post-radiation cystitis, proctitis, and post-radiation, radiation causes pain, and radiation can also treat pain. So it's how you use it and how much the patient suffers. You need to have a balance, and I think most of the radiation oncologists are competent enough to tackle both the things to ensure enough radiation that it does not cause radiation-associated pain, and if there are bad vertebral mets causing really bad pain, they are competent enough to even treat those vertebral mets with radiation. Of course, that's the last resort. Arthritis and migraines are not related to cancer pain, so this we need not work, because many times patient comes with arthritis and we think it is cancer related pain. No, it is not cancer related pain. So pain assessment is, we do not have any gadgets to find out how and what the pain is. The simple is clinical assessment. So we have various types of pain intensity charts which help us to find how the patient is doing as far as pain is concerned. It could be just a verbal, it could be on a scale, or it can be just a visual analog. So different analogs are used for the assessment of pain. The most commonly used amongst all these plethora of things is the McGill Pain Questionnaire. This is standard all across the world. I'm not going to into details of it, it's a big form, but this is the standard method of assessing pain in all patients of cancer treatment. So when you're treating it, there is a purpose. The WHO has set a pain ladder. We treat it as step 1, step 2, step 3. So this was developed in 1986 the idea was to legitimize the use of narcotics, because before 1986, the use of, or the role of narcotics in pain management was not defined. So this came into being, and that is why the association came up. And then they legitimized the use of narcotics, and everything was regulated by WHO as far as treating patients with pain, because there was a lot of dilemma about narcotics in those periods. So this is what they said. 5 essentials: by mouth, by clock, by ladder, by individual, with attention to detail. So this is the basis of WHO pain management. So it is very stepwise. And remember, the first thing, everything is by mouth. So we are not talking of pain management as IVs or intrathecals or anything. We are starting it with mouth. And that is why you have a step ladder 1, 2, 3 method of treating pain as far as patients are concerned. They have modified this. I'll just give you this is basically the outline which probably everybody needs to keep in mind, that you start with mild pain agents, then you go to moderate, and then you go to severe. Use of morphine is now also indicated in moderate. I think this is an old slide. So use of morphine is now also indicated for moderate and severe pain. These are the agents we use. We are also using antidepressants, tricyclic antidepressants, antipsychotic drugs. So there are a lot of plethora of drugs that are used in a step ladder pattern to alleviate pain in cancer patients. Various non-pharmacological methods are also involved. The most is cognitive behavioral. So whenever you have a patient who is having pain, who is managed by these drugs, you also require the help of a psychologist, because after all, that is also causing much of, or rather adding to much of the pain. So involving a psychological counselor is an essential part of the pain management as far as cancer patients are concerned. When we talk of opioids, a plethora of information, as I said, I'm not going into detail because there's too much of detail as far as morphine is used, and the current audience are never going to use it. So these are the various methods that we have where narcotics can be given to the patients in various forms in a step ladder pattern by a pain palliative care physician as and where it is required. These are the newer invasive modalities, and now what is happening is these new invasive modalities are coming back to as far as as an adjuvant to your original pain management. Last slide. The problem is many people die in pain, many more people are dying with pain, and even many more are living. And we are the only help for them. I think understanding that there is something called pain palliative care physician, pain palliative care departments, referring patients to them and getting the patient alleviated of the pain is our job. That is what I would like you to understand. Thank you.